Brilliant. And obviously, as the meeting goes on, feel free to flag them to me or anyone else in the team. So I'm going to go in the order of my screen, and the first person is Aisha. Hi, Aisha.
Hi, my name's Aisha Marshall. I work in the North East, so I'm over in Sunderland and South Tyneside. I work in an integrated trust, so I do cover primary, secondary and also care homes. My role is a tissue viability nurse consultant, and referring patients, interesting one. We work with a local spinal injuries hospital, so I would refer if they fit that criteria for spinal injuries. However, patients without spinal injuries wouldn't be received or considered for reconstruction. I used to work in Yorkshire also, and again, it was referral to a spinal injuries unit that would consider reconstruction. So at present, no, only unless it's spinal injuries.
Okay, and we'll come on to talking about that. That's really interesting. Thank you so much. Susie, could I ask you to introduce yourself?
My name is Susie Pramod. I work at the Christie Hospital, Manchester, so especially at tertiary care. My role is tissue viability specialist nurse. I do look after patients with the pressure ulcer, same way quite a lot of oncology wounds are also being looked after by me. And when a couple of occasions, the patients have come to me with the pressure ulcers category 4, and the surgeon, the oncologist said it is pressure ulcer, so I had to go into detail, ask them to do the scan to make sure there is no disease progression to that particular area. It is not the disease causing the wound. And I have found recently two patients had disease progression, which was misdiagnosed as pressure ulcer. So from my part, if there is no cancer in the area, they think it's a pressure ulcer. Or if I find a pressure ulcer with no cancer, I will refer them to category 3 or 4 pressure ulcers. I will refer. I have referred a category 4 pressure ulcer, which was actually not it was not a disease progression. And a category 3, I would try all other methods before I refer these patients to the plastic surgeons.
Thank you, Susie. That's great. Thanks for being here. Jackie.
Hi, I'm Jackie Fletcher. I cover the whole of England. I work across all different settings. My role is as the clinical lead for the Stop the Pressure programme and for the pressure ulcer arm of the National Wound Care Strategy. I obviously don't currently refer patients because I don't see them, but in my previous roles as a tissue viability nurse, whether that's in an honorary role or as a substantive role, it's been a similar experience to Aisha had. Plastics would really only see patients if they were spinal injury patients. And the only other patients we would occasionally get referred were young people with chronic conditions, but with a reasonable lifespan as a quality of life improvement. Other than that, they were not considered suitable generally for referral.
Okay. Thanks, Jackie. That's really interesting. That's my screen. Maria. Inez.
Hi, good afternoon, everyone. I'm the lead tissue viability nurse, and I cover 2 hospitals. So I work in a private sector, but we follow all the NHS guidelines. That's why I was interested to be part of this group. I cover all areas. So we have inpatients, outpatients, surgical, intensive care, oncology. So more or less all sort of patients. And we deal daily with patients with the pressure ulcers. We are lucky because, especially because we work in private, we don't have an issue with budgets, and we work a lot as a multidisciplinary team. So as soon as the patient comes, he will be assessed by a consultant. And then if the patient has any sort of skin or wounds, so skin damage or any kind of wounds, they will refer to the tissue viability team. Then we will assess the patient, and then we can automatically refer to the relevant team. So we work closely with the surgical team, with plastics. So we're lucky in that sense that everybody will be aware of the patient. It's easy to communicate because we, despite covering a large area, because patients can come from anywhere in the world, or even throughout UK, we are a smaller hospital, so it's not like a big NHS trust. So communication, it's easier, and to work as an MDT, it's easier. And that's me.
That's great. Thanks so much, Inez. Claire.
Hi, I'm Claire Porter, work in Leicestershire. We cover 3 hospital sites, but we, in my team, in the plastic surgery team, we also offer a community outreach service twice a week. So we will work in close partnership with our district nurses and tissue viability nurses. I've seen a transition in people's attitudes and approach over the last 20 years. When I was first a plastic surgery nurse 25 years ago, we seemed to do, it wasn't a frequent operation, but it was a regular operation on the wards where we would undertake surgical reconstruction. And I think over the last 10 years, it's become unfashionable, maybe because of the evidence, but because I think consultants have become so specialised, especially plastic surgeons, specialised in, you know, really fancy surgery. These patients, I feel, are unattractive to them. So they will sometimes opt for a more conservative approach. My experience is that tissue viability nurses in the community are struggling to have access to the surgical teams. They don't know which way to go. And quite often they'll bounce between our plastic surgeon, the orthopaedic surgeon, and no one wants to take ownership. So we've been working really hard to try and be that connecting bridge out there in the community and assess the patients. And actually, I think there are probably more patients out there that are suitable for surgical reconstruction than we all know about. But just because of the hurdles getting into the right team in the right places, and I totally agree with what you guys have said. If you're attached to a spinal unit, you've got an open door, and it's almost like it's a relief when you know the patient's been in a spinal unit in Sheffield, because you know they'll take them back and they will consider them. We are slowly making progress in Leicester. We are undertaking some surgical reconstructions. Obviously, not many patients are appropriate for them, but I feel that the ones we do decide, it massively improves their quality of life. So thank you for involving me with this. And I've been looking at all the paperwork and all the hard work you guys have been doing. And it's a minefield. So, but yeah, thank you.
Thanks so much, Claire. And that's the points you raise are things that we really want to, as a group, have some conversations about today. And, you know, our output from this work, or one of the outputs, will be trying to draw all this work together into a report that hopefully, along with other work in the area, will make some inroads into some of the change that's needed. Nikki Kimpton. Sorry, Nikki, that's not your surname anymore, is it? I'm really sorry. You'll be like, who?
7 years now. So I'm Nikki Elwood-Watton, previously Kimpton, tissue viability nurse consultant in Cornwall community. So we cover the whole of Cornwall. We have automatic referrals to our service for all grade category 3, 4s, unstageables and deep tissue injuries. In terms of referring for reconstructive surgery, we do have direct access to the surgeons and orthopaedic surgeons. The biggest problem, I think, is their agreement between themselves as to who should take that patient. So we do have a policy shared with the acute unit that says they should have an MRI. They should then go under medical admission to make sure they're medically fit, and then be referred for orthopedic review once they're in hospital. But actually, I've spent hours and hours and hours in A&E with patients trying to get and sort of gone in and met the patient in there and stood there as patient advocate, trying to get them seen by the right consultant, only for them to be discharged after being seen by all of the consultants, and then readmitted again 3-4 days later because they're at risk of sepsis, and then ending up under orthopedic surgeons anyway. So the policy doesn't actually work. I think the other issue here is that our spinal unit is in Salisbury. So if we have a spinal patient that's under the care of the spinal unit, and the spinal unit would prefer to do the reconstructive surgery, the patient is actually reluctant to go to the spinal unit, because if they've got a package of care here, it means them losing their package of care because they want them to stay in for 6 weeks. So they would lose that package of care, despite the fact that the patient says that they will remain on bed rest and they'll do everything they should do in order to come home early. The spinal unit won't actually operate if they don't stay in the spinal unit. And we use pressure mapping data prior to referrals so that we can demonstrate we've looked at the mattress and we've looked at their seating, and all of those things from a pressure point of view. We've got to the best level we can so that they've got that data at the same time as well.
Okay, thanks, Vicky. That's really interesting, and definitely be things I'm sure that will come up again in the conversations we have today. Nikki Richardson.
Hi, so I'm the lead clinical nurse specialist for Torbay in South Devon. We're an ICO, so we cover acute and community and care homes and the like. We can refer direct in, and we have a very good relationship with our orthopaedic surgeons. But when we start thinking about pressure ulcer reconstruction, it's the plastics team, and we don't have a set plastics team here. They only visit twice a week. So communication is a bit of an issue. We have had 2 of our patients recently offered reconstruction, one of whom took it and the other refused. Both of them are spinal, and we have the same issue as Nikki because we come under the same spinal team up in Salisbury. And one of them, and that was the issue, one of them has gone up there and he spent his 6 weeks. I tried to get an update on him today, actually, to find out how he's doing, because I'm not too sure. They didn't involve us, and I think that's the difficulty we have, is that it's about his onward journey, because actually this gentleman sits for his job. He works in a supermarket and sits for his job, and I don't think they've really thought that through. So they've done the reconstruction, but whether that will last is another issue, because it was all about getting his independence back, and actually he just wants his independence to work, which was the main problem in the first place. We'd certainly like to consider referring more through, but like I say, that does, the same as Nikki, tends to be the spinal patients more than anything else. They see a pressure ulcer, and that's what they see when they come in. We are more fortunate than Nikki. Ours do go straight under orthopedics if it's spinal, but if it's pressure ulcer, but again, they still don't consider reconstruction at all.
Thanks so much, Nikki. Again, as with all the information we're hearing, really interesting, lots to consider today. Sue.
Hi, I'm Sue Murphy. I'm the clinical and operational lead for tissue viability for Serona Care and Health. Serona covers North Somerset, Bristol and South Gloucestershire, and we're a primary care. So I've been in tissue viability for many, many years, and I've had quite a lot of different experiences. I feel quite passionate about this area because I've had young people under our care who I do always refer into plastics for an opinion. And I've learned that the quicker you get on and do something about these grade 3, grade 4s, the better the outcomes for the patients. there seems to be a real reluctance though from our plastic surgeons, and we've had the same issue where they've been passed from orthopedic surgeons to plastic surgeons. One that resigns, sits with me, young man, very active, paraplegic. They sat on him for a whole year until he was admitted with sepsis, and then they finally did his surgery, and he did very well after that, but it was a year of misery for him. And my brother's paraplegic, and he unfortunately ended up with a pressure injury. He works all over the place, flies all over the place, and long haul flights for his work, and unfortunately ended up with this pressure injury. And I was really worried about him because of my past experiences. He was so fortunate that he was seen in Gloucester by a consultant that actually came from Bristol, who used to go and do sessions with Gloucester, and he took him straight in and did a flap for him, and he has done brilliantly, and within 8 weeks was back out, thankfully. And I just, from seeing those different experiences, it just feels like it's potluck who patients see consultant wise and whether they'll act. And yeah, that's why I'm so interested in this study, really, because it doesn't feel right that people have to wait for so long to have their surgery or a chance at recovery.
Thanks so much, Sue. Thank you. And sorry, I'm just having some problems with my screen. Bear with me. Andy.
Hiya, good morning, afternoon, where am I? I've forgotten what the questions were. So.
Oh, sorry.
No, I'm joking.
There we go,
Right.
Sorry.
No, I'm joking.
Can you see? There we
Yeah.
go.
And here I am. Look, I'm Andy. I'm a tissue viability nurse in the northeast. I'm just like 30 miles south of White Ayrshires in Sunderland, and we're from North Tees and Hartlepool. So we work in a combined acute and community. So we also look after care hubs too. And I've already told you I'm a TVN, and we don't here have a direct referral route to plastic surgery. As such, we can ask the GP to refer to plastics, and they generally don't refuse. However, I think in the 10 or so years I've done this job, it's been significantly less than one patient per year that have actually seen patients, and where the patient has subsequently progressed on to having some plastic surgery for their pressure ulceration. We have got access to a nice plastic surgery nurse who works for our hospital over the river, so South Tees Hospital, because we don't have our own plastic surgery service here. And that's often a good port of call for us, because the plastics nurse can come and see the patient for us, and then she can pass that information on to the plastic surgeons who she knows better than we do, in terms of whether she thinks the plastic surgeons would give any further surgical input, so she can make her own assessment. So despite that we have got a plastic surgeon who has a little bit of interest in doing this type of work, it's very, very infrequent where there's anything happens at all with regards to surgical reconstruction. Just in terms of I mainly work in community as well. My colleague Chris is on the call, and she mainly works in hospital. So Chris can give her own opinion on this too. But in terms of, we tried doing some exploratory work in looking at where patients sit that got osteomyelitis, because it's very difficult, because if you have a pressure ulcer that's got an underlying osteomyelitis, then we need some input. It's a medical issue generally, not a nursing issue. And we kind of run into walls at this point, because the orthopedic surgeons don't want them because it's an infective issue. The microbiologists don't want them because the microbiologists want to take samples, and nobody is willing to do a sample. Plastic surgeons don't want them because they're not going to take them until the osteomyelitis is sorted out. When we tried to put a pathway in place, or tried the very beginnings of a pathway, but there isn't a national pathway on managing these patients where there's an involvement of bone. It's very difficult to try and get consensus of opinion from the three different areas of surgeons about who's going to take responsibility for it. And a pathway itself is likely going to be impossible because of the variety of patients that have this condition. The best we got was that where we come across these patients, we need an MDT between plastics, orthopedics, microbiology, TVNs, and podiatry or however, to pick these patients up and discuss their best pathway for them. But what we find in practice is that it doesn't really happen, and most patients with osteomyelitis are kind of picked up, seen once, treated, and then discharged. And who actually knows whether their osteomyelitis is resolved after whatever course of antibiotics they've had, because it's never picked up again.
Thanks, Andy. Again, I think, you know, there's been a lot of sort of introduction to the role of care pathways and different care pathways, the types of patients and the heterogeneity of patients, and these are all things that we want to talk about. So this is great. Thank you so much. And finally, Chris, who's been partially introduced by Andy.
I have, yes. I work alongside Andy. I'm actually working from home today, so I'm in a nice quiet bedroom office, and Andy's in a very busy office. We, like Andy said, we both work for North Tees and Hartlepool Integrated Trust. I predominantly work in hospital. Find it very, very difficult to get patients seen. We get patients seen by the plastic surgeons as inpatients because we have a satellite service from over the river. But they never ever go to reconstruction. The plastic surgeons see them, they decide on a plan, and then they say that it'll heal in time with good care, and that's about as much input as we get. We do have a spinal unit over at James Cook, which my colleagues have tried to get patients in. It's very difficult because patients tend to get bounced around, as Andy said, between specialities. We have had a couple of spinal injuries patients who've actually had surgery, but I've worked for 16, 17 years in tissue viability. So 2 in 16, 17 years isn't a lot at all. It's just really difficult. Myself and Andy obviously work together, so the problems Andy described, I have the same problems as well.
Okay, thanks, Chris. Thanks, everybody.